Good afternoon, everybody, and welcome to the Global Heart Hub Inspire Speaker Series. My name is Neil Johnson from the Global Heart Hub, and I'm delighted to welcome you this afternoon here in Ireland, for some of you this morning, and for some of you late afternoon or evening. We're delighted to welcome you to the first of our Inspire series of 2022. And before we start, I want to say a special hello to all of our affiliates currently in the vicinity of or in the region of the conflict zone, and know that we stand united with you at this very difficult time. Next slide there, Jackie. For those of you who are not familiar with us, I just want to take this opportunity to introduce the Global Heart Hub. We're a relatively new entity incorporated in 2019, and I believe we're the first global non-profit alliance of heart patient organizations committed to providing a voice for those living with or affected by cardiovascular diseases. And we operate really at three levels. We have councils, which are effectively working groups of patient organizations who have come together around specific cardiovascular conditions. We are very much trying to build and establish and strengthen the cardiovascular patient community. And we do that through the work of the councils and also through collaborations with various organizations, some of which are listed here on the slide. Next slide, please. In terms of what we do, we're very much obviously about disease awareness, cardiovascular disease awareness, and also awareness of the need for engagement with the lived experience of the patient voice. To that end, we're very much focused on an advocacy agenda, advocating for the needs of those living with or affected by cardiovascular disease. And in so doing, we have established the Global Heart Hub Academy as the mechanism by which we develop the capacity and capability of the patient community to engage in cardiovascular disease advocacy. The Inspire Speaker Series, next slide, Jackie, please. The Inspire Speaker Series is, as the word suggests, an attempt to share with you inspiring stories presented by inspiring individuals who have, either through their own lived experience or as advocates, done great things. In many cases, the people we're speaking to in the series may actually be coming from other disease areas, because we believe we've a lot to learn from the experience of the more developed advocacy work on some of the other disease areas. And in this regard, today, I'm absolutely thrilled that our speaker for the first Inspire series of 2022 is Dr. Durhane Wong-Rieger. Now, I had the privilege of meeting Durhane, I would say, almost 10 years ago. And at that very first meeting, I was impressed by her knowledge and her experience in advocacy. And more recently, in fact, late last year, coincidentally, we shared a cab together in Montreal. And I remember asking her to tell me a little bit about her work in the area of rare diseases. And at the end of the conversation, I suggested that perhaps someday she might come and share that with the cardiovascular patient community. But of course, Durhane is not only president and CEO of the Canadian Organization for Rare Disorders, she's also chair of the Canadian Heart Patient Alliance. And she has demonstrated very strong leadership and involvement in multiple other patient-centered organizations, including the Institute for Optimizing Health Outcomes, the International Alliance of Patient Organizations, the Canadian Hemophilia Society, and the Asia Pacific Alliance of Rare Diseases. So clearly you can see this lady has accumulated a very considerable experience in the world of patient advocacy. She, of course, holds a PhD in psychology from McGill University. She's a former professor at the University of Windsor, Canada, and she's a widely published author. Durhane, we're delighted to welcome you to this forum today. And as we've agreed, we're going to take the form of a conversation rather than a slide presentation. And before we get into the conversation, if I can just move the slide forward and just mention to people that we'd encourage you to use the Q&A function as a means to register your comments or reactions or questions, and hopefully before the end of the session, it's a 1-hour session, we'll be able to take some of your questions and pose them to Durhane. Equally, from the point of view of the development of this Inspire series, I'd ask you to complete the post-event questionnaire, which will automatically arrive in your inbox once you have been an attendee. And your answers to that questionnaire are very important to us because it'll help us to continually improve this education format. And also just to say to you that the webinar is being recorded and will be available on Global Heart Hub website. And for my final slide before we go into conversation with Durhane, I'd ask you to mark your calendar for the 11th of May, same time again, 15 to 1600 GMT, for the next Inspire speaker series. And in that, we'll be having a conversation with John Barrick. John is past president of Stroke Alliance for Europe and current Safe Patient Voice Ambassador. But back now to Durhane. And again, Durhane, it genuinely is a great privilege to have you, because I know how busy you are. You're just back from Dubai. Do you want to tell us a little bit about what you were doing there?
Absolutely. You can see I still have the Dubai logo on my background, and we're so very excited. We were there to celebrate Rare Disease Day and to celebrate the passage just recently of the United Nations resolution addressing the needs of patients and families living with rare diseases. And really, it's the first recognition officially from the UN of that nature for rare diseases. Important for us because it recognizes rare diseases not just as clinical medical, but also a host of the social, economic, occupational, educational, discrimination needs. And it allows us now to actually be able to work even more strongly with the other world organizations to actually address the needs of patients, families with rare diseases. So it was a great celebration. I jokingly said at the beginning, it was great. They gave us one of the pavilions at Expo 2020. We had 2 queens and Secretary General from the WHO. We had the whole tower lit up for us, the inside dome lit up for us. It really was a special occasion, but more importantly for us, it really is an opportunity to really launch into a host of other kinds of actions on behalf of rare diseases.
And of course, the fact that you were there and that this had resulted in a UN declaration really underlies why we're having this conversation. It just shows you how far the rare disease community has come in terms of its presence and its advocacy. And specifically, I guess why I was interested in speaking to you and looking at what we can learn from rare diseases is, as the name suggests, it's a rare condition. And what we're talking about today, cardiovascular disease, is quite the opposite. It's a very common condition. Yet for some reason or other, the patient voice has not been as strong. And that was really the reason why the Global Heart Hub was formed. And the purpose of today's discussion is trying to explore what we can learn from that experience and how we can move our agenda forward. But firstly, can I just start by asking you just to share a little bit about your own background? I mean, I've obviously listed off a very impressive list of engagements that you have with other organizations, but tell us a little bit about yourself and how you've ended up on this journey of advocacy.
I think, like most advocates, none of us really come into it, by calling, right? It really is something that we're drawn into. I have 2 children, both of whom were born with rare conditions, different rare conditions. A daughter with a rare disorder that's really never been diagnosed, and my son, who was actually born with a rare cardiovascular condition, which was clearly diagnosed from the day one, and actually was very well managed because there were clear sets of guidelines that we could follow and clear sets of milestones that we could monitor. So really very much part of that. I've got a husband who actually has, interestingly enough, Parkinson's disease, which is kind of not rare, but really still within that realm of really challenging neuromuscular disorders. He has a rare motility disorder called achalasia, and he also has a chronic cardiovascular condition, which in some respects, really takes a backseat to everything. And I think, you know, when we talk about it, that's the, you know, kind of a trigger, you know, when you and I were having the conversation as to, you know, from my own experience personally, that recognition that, you know, in terms of other conditions, you know, certainly Parkinson's and certainly in terms of the rare diseases, there's strong patient advocacy. But with the cardiovascular condition, even for him, his father died at 45, you know, of a heart attack. He himself had bypass surgery, you know, in his mid 50s, and yet he does not really consider that to be something that he really needs to speak out and take action on, as opposed to some of the other conditions. So that's from it personally. I was actually drawn into advocacy on this front by my volunteer work with the Canadian Hemophilia Society at the height of the blood, what we call the blood scandal, and getting, you know, sort of an understanding of what went wrong and how come so many people got infected with the HIV, hepatitis from the blood disease, and of course, a very strong advocacy community. But I will say very clearly, and this is again something that's really framed my thinking, prior to those incidents, the hemophilia community were not what you call advocates. They were really patients who were really struggling the best they could and really throat when they had, you know, new products, but they were not there on the front lines, and it transformed this community into being, you know, radicals, you know, demanding, you know, not only justice, but new products, changes in terms of policy and guidelines. And I think, again, we can learn a great deal from, you know, what almost, you know, serendipitous kinds of events can do, and again help inform us as to maybe why some of the challenges with the cardiovascular advocacy.
Yeah, I'd like to come back to that in a minute. The whole idea that you know, the Hemophilia Society was spurned or born out of a particular emergency. But just back to, as I mentioned, you know, I first met you probably 10 years ago, and at that point in time, I think we were part of a bigger group in general patient advocacy, and you were very clearly representing the rare disease community. And then last year, you very kindly participated in our inaugural Global Heart Unite Summit. And it was after that summit, you said to me that, you know, after you engaged with the group and that, wow, you know, there's just a whole underdeveloped area here that needs to be you know, exposed in terms of advocacy, deficiency, and so forth. And then I see now you're chairing the Canadian Heart Patient Alliance. Does it, you know, for advocacy to take off, let's say, in our community, is it that we're missing an urgent call to action? Or, you know, you mentioned hemophilia, there was an emergency and there was a response. Why do you think, you know, we don't have a strong voice in cardiovascular disease?
You know, there are in fact some strong voices, as you know. If you look at the FH community, if you look a bit at the arrhythmia community, there's been some really strong actions, right? But I think, unfortunately, the same is, and unfortunately, I keep drawing my personal experience, it's one of those conditions that sits there in the background. In some respects, it can be managed in many cases, you know, so you take a statin, you take, you know, whatever kind of heart medication you might have. A lot of it has to do with personal, you know, sort of health practices, etc. There isn't the perception that there is something that needs to be done. There's no urgency to it, even in situations like you have strokes. And of course, heart attacks are urgent, but there is that sense of, you know, what else could we have done to actually either prevent it or to actually take care of the patient in order to avoid some kind of catastrophic event. And, you know, so unlike cancer, you know, where I think there's been a huge, you know, uptake in terms of advocacy, because there's this, you know, need for new medicines and the ability to intervene, you know, and get that diagnosed quickly. You know, in some respects, it may be that cardiovascular is one of those really sleeper conditions that there doesn't seem to be a whole lot that one can actually rally around to actually call to action. You know, you can almost put it on the side of like diabetes. Like, you know, diabetes, yes, it's an active engagement, but really not the same kind of advocacy as you would see in arthritis or that you would see in cancer.
Yeah, and I think the urgency issue is something we do need to address. And I know we've recently again engaged with you around an initiative that the Global Heart Hub is undertaking around ASCVD. And even for myself, once I sort of started to realize how significant the burden of atherosclerotic cardiovascular disease is, it started to make me think that really, so for example, right, we know that 85% of all heart attacks and strokes are attributable to ASCVD. Okay, so ASCVD is actually the cancer in our world, and but we do know what the risk factors and causes of ASCVD are, and we also have the treatments. So is there a sense that there's perhaps a complacency that has developed globally around cardiovascular disease, and do we need to shake that up? Is that what we need to do?
As a psychologist, I feel like I should know better, but I kind of don't. I do think that with ASCVD, most of the times it's a sleeper. Unlike cancer, where you have cancer, you actually experience a great deal of pain. You actually experience the sense that this disease is progressing rapidly and you really need to halt it. And, there are, in fact, interventions, right? You're on medications, you're brought in. So there's a sense of an urgency. It's a crisis. And I think the difference with a cardiovascular condition, ASCVD, which my husband actually has, he has FH, most of the time, nothing's happening. He has bypass surgery. He recovers from bypass surgery. Most of the time, nothing happens. And I think that's the challenge, is that you don't have constant reminders that you have a deadly condition that is ticking away at you. And by the way, there are things that could and should be done. We don't have a whole, that with ASCVD, you had statins for the longest time. And it was like, okay, you got a treatment, but there was nothing else coming. And then we end up with this, PCSK9s that came out. And it was like, yes, there was something. And then there's more. And there have been things, but none of them were really seen as, okay, this is going to save your life. It's going to make a dramatic difference in terms of how well you're going to be able to survive and perform. So I don't think we've had those, but I think it's a catch-22, Neil. We haven't had them because there hasn't been a call for them. Nobody said, "Well, get me something better. Let's do better here." It's the number one killer. Like, what on earth, could be more urgent than that? And yet, there's not that call to say, "Where's my next treatment? How do we make this better?"
Yeah, because sometimes it strikes me that if an alien were to arrive into our world and we were to say, "Hey, there's this disease, it's killing millions of people. It's a slow burn. 80% of it is preventable. We have treatments. We know largely what the causes are, but yet we're accepting it." I just think there is an urgency piece here that we need to figure out, and maybe this is where we can learn from the other disease areas. And going back to your role in the rare disease community, if you were to look at the successes in rare disease, or indeed any of the advocacy journeys you've been on, are there any learnings there that you would be saying, okay, this is what they did in rare diseases, this is what they did in hemophilia, we need to do something similar in cardiovascular disease? Any?
Yeah, certainly, I always think about, advocacy as a bit of a pathway. Almost always advocacy requires person, a case, stories. People rally around not diseases, not causes, not, treatments. They rally around individuals. You need to have, unfortunately, people who can come forth and say, this is me, this is what is affecting me, this is what I need, though. There has to be a need that can be addressed. That's important. A lot of times the cardiovascular need is not really clear. What do I want you to do on my behalf? Yes, we can do things like, the bike rides, et cetera, to raise monies for better research, but that's sort of nebulous, right? Yeah, I'm happy to give, but so you have to have a need. And I think in the rare diseases, and then certainly in cancer, you have individuals that come forth and you see it over and over again, right? Even the cardiovascular so-called, awareness campaigns, they're not that much around individuals. I will say the two cardiovascular conditions that really make it clear as to why this pattern does work. You look at FH and you look at what's done with FH. in the US, FH Europe, where individuals have come forth and they've been able to identify. And you look at the Arrhythmia Alliance and the very beginnings of it, right? This is, important to be able to diagnose early, to prevent, to detect arrhythmia and to be able to intervene for children. Those two conditions, though, actually got a big boost when you actually had a treatment, with FH as well, right? The transitions into the PCSK9s and the ability to actually intervene for children. The same with arrhythmia. The defibrillators became a huge, cause for this community to come together and bring everybody else on. I will say in the beginning, most of us thought, like, really? You think we're going to have defibrillators in, sports arenas and we're going to be able to replace them every year? People thought that's nonsense. How can we afford that? And yet the campaign worked, right? Because it does save lives. Mm-hmm. The challenge is that you don't always have those kinds of sparks on an ongoing basis. But I say again, my statement is that we don't have many of those because we're not calling for them. Yeah. And the challenge, as you say, even though 80% of deaths due to CVDs can be prevented, a lot of it points back to individuals. I mean, what are you advocating for? You're advocating for what? For other people to live better lives? Could be, but that's a really challenging kind of an act. Mm-hmm. So there has to be individuals that have they're willing to be present, have a need. The other thing you have to have is kind of what you've done. This is why I'm so delighted actually with this Global Heart Hub. You've got to bring in others. You've got to make this something that's relevant to others, certainly other patients and families, others that are working in that area, but even more that has to include the public. Think of what happened with HIV. You had the individuals. Now they had to overcome a huge stigma because it absolutely started right in the gay community. And they actually did a very clever thing. It kind of became contextualized with the whole sort of a gay rights movement. So almost to be against HIV and not support it is to be seen as being against gay rights. So the two actually came in strongly together, both of those, right? But you also had the public that became very sympathetically involved, and the celebrities helped a whole lot, in order to make that into a truly public disease. I mean, in some respects, HIV was not a public condition. It was not something that most people felt like, okay, I'm really at high risk to get it. But you had tremendous public identification with the community. And that's something that's really important. I think the challenge with cardiovascular conditions as well is that there are so many of them. Yeah. And I think, what you're doing now is, being able to bring that community together, but there still has to be, what are the issues that are highly specific? The other thing that has to be there is it has to be something that can be done, that can be dealt with. As I say, you can get a lot of public attention and a lot of public support, and you can raise money for research. What you really want is something that you can push into the policymakers, push into the system and say, you need to take action to do this. And I'm not sure we've articulated what this is that we want policymakers and health systems to do. In cancer, it became clear, right? We want you to not only fund new treatments, but we want you to make them available to everybody. We want you to do, with rare diseases, we are begging for diagnosis and new therapies in the orphan drug, legislation. We want you to do this, and we want you to change, the rules so that we can stimulate that kind of research. The ask is not as clear. I mean, FH has done a good job on it because they push for having things like, better cascade screening diagnosis. But it's kind of a soft ask, and it's not something that I want a law that says everybody who has, FH is going to get their families tested. That's not going to happen. What is it that we're asking you to do? It's not a clear ask. And I think that's a challenge. So, but I do think that what is possible and what happens over and over again is the ability for the patient community to actually take charge and to actually begin to be in charge of many of these campaigns. And what strikes us oftentimes is that when we go into, many of the disease, conferences, international conferences in cancer and rare diseases, in, many HIV certainly, but beyond those, many of those, you see patients integrated with the researchers, integrated with the clinicians. You see them doing papers and doing posters. You don't really see that in cardiovascular. And I haven't seen that community own, actually the driving of research and driving of, the clinical changes. And I think that's something that has yet to come.
So I'm trying to summarize what I'm hearing from you, when you're looking at the successes, if you will, in the rare disease areas, or some of the areas that you've been involved in, you've emphasized the fact that there needs to be a very clear need. You've emphasized the fact that there needs to be an ambassador or a voice. You've emphasized the need to be able to push for a quick win. There needs to be something that the policymaker or whoever can relate to the ask. And you've mentioned the piece about integration, the fact that you know, you don't do a solo run. You have the patients and the clinicians or the academics. Now, I think from where I sit, we have the need. There's no question about that. I think the point is that we haven't articulated it. I mean, I could list for you, you know, 20 needs right now that would go right across the cardiovascular spectrum of conditions that are not unlike what you've described. So, for example, in rare disease, you're looking at novel therapies. In cardiovascular disease, there are therapies that there isn't equal access to. You know, there isn't, and there are new treatments that are not being promoted strongly or equally across internationally. We have conditions that are, you know, hypertension, for example, one of the biggest causes of heart failure, heart attack, stroke, atrial fibrillation, the cause of 30% of the most devastating stroke. I mean, the need piece is very clear to map out, but I think what we're missing are individuals, I guess, who will stand up and present these in a way that attracts attention. And so the question then is, how do we find these inspiring individuals, or these ambassadors, or these people who will elevate this and bring people with them? Because it would seem that from what I'm gathering from you and from previous conversations, it actually does come down to some leading lights, some individuals who fly the flag.
Boy, you articulate what I said so much better. I should have just sort of fed you the thoughts. You know, you're exactly right, though. I mean, it is kind of being able to put, first of all, those conditions out there. I love what you said about the fact that we've got, you know, novel treatments, but they aren't available. We've got, in fact, interventions and initiatives, but they're not being recognized, and even in areas where they are available. I mean, it's the same with rare diseases. We have, you know, orphan medicines, but they're not equally available. And in fact, that's a huge challenge, because obviously many of them are, you know, quite expensive. So how do you make them available? This whole UN resolution, right? This is something that points to the other needs that they have, but, you know, it gives us the framework by which we can ask for and we can engage. The most important thing that we're doing now, and what I say with this UN resolution, it is not a gimme. What we're going to now have to do is we actually have to take it down to the grassroots levels. We are developing toolkits that actually help to train the patient organizations on how they can actually use what's in that resolution to ask for certain kinds of policies, or certain kinds of changes in their health systems, to be able to engage others to support them. And what it gives them, though, is that to say, you have a right to this. You're not asking for this because it's something that you just want. The UN has said this is, in fact, an important condition. It has all of these ramifications, and you as member states must step forward to help address these. They're not going to give you anything, but it allows you to say, this is the commitment that's there. Let us now work with you to make it happen. But we have just created, for instance, last year, what we call the Global Access to Rare Disease Medicines Working Group. We recognize that challenge, you know, and it's even worse in the rare disease communities, because, you know, some of them are so expensive, very few people can get access to them, unless we are very deliberate about how do we bring them into the developing world. This is not going to happen. Think about diabetes and how they created the insulin programs. Think about HIV and the medicines programs, right? Those are things that were not just good for the communities they were going into, they rallied the entire community. I mean, hemophilia right now is positioned on how do we actually get clotting factors to our members who are in many, many, you know, underdeveloped kinds of systems. And this is something the whole community is rallied around. It continues then to raise the profile and engage. So you're absolutely right. It's finding those causes that you can actually use, but the goal is you have to train and work with the groups on the ground. You have to have strong patient organizations, and you have to engender those on the ground.
Yeah, so there's a couple of points you've made there, which I'd like to follow up on, because they're really relevant. The first thing is that it's sort of ironic that you have this, and I don't mean disrespectfully to the rare disease community, but you have this community of people with a rare condition, and yet you as a community are able to get access to orphan drugs and to make a claim for why these people need to be treated. And we in the cardiovascular community are representing a far more common condition, and we are not achieving this success in terms of equal access and so forth. So you mentioned though there about the right to health. I mean, would you say, is it too simplistic a view to take that the approach from the rare disease community is a rights-based approach? Is that the underlying sort of?
That's right. I mean, and that's what, for instance, with the universal health coverage. So the WHO has it. The universal health coverage was passed by the UN in 2019. We actually made the case when the UHC was being passed. We lobbied very hard, all the member states. We actually have a line in that UHC declaration that recognizes rare disease as a disadvantaged community that must be taken care of. So that for us was important, because without that, we did not feel we had the same rights. People said, well, we mentioned disabilities, and there was a no, we're not disabilities. Yes, many of our people are disabled. Unless we have something like that, it's harder for our patient populations and our healthcare populations to be able to say, we have a right. It's guaranteed under universal health coverage. If you're adopting universal health coverage, here's what you need to do, and you need to make sure that rare diseases is there. Now, our job is to figure out how it's going to be there, but we now have a right to make sure that you're going to acknowledge what our requests are. So it is a rights base. And I think it's important as well, you know, I feel sometimes like diabetes, like cardiovascular disease, and I go back to my poor husband as well all the time. If people kind of feel like it's my fault, and we've made it kind of their fault, you know, it's all preventable. And the fact that, you know, you're not doing it, you know, well, then it's kind of your own fault. It's sort of like, you know, not being as wealthy and successful in a wealthy country as you are in a country that is, you know, lesser developed. If you're not wealthy in a lesser developed country, it's really understandable. It's not. If you're not, you know, wealthy in a well-developed country, it's sort of like, well, it's kind of your own fault. You know, all the opportunities are here, and you know, you just haven't risen to the occasion. It's not your fault. Circumstances and conditions are what they are, and we've got to get that mindset out of people. Yes, of course, you still need to take responsibility, right? But it doesn't mean that, you know, you do not have a right to demand that there be more done by the system and for the system. Earlier diagnosis, good careful monitoring, access to the most advanced therapies or targeted therapies, the demand for better research. I mean, we're everywhere looking at gene research that's going to target, you know, diseases. I mean, where's cardiovascular in that? I'm sure that if you look at stroke, right, you know, do we really know kind of what causes strokes? You know, what that patient, we think of them as this big amorphous group of patients who actually get stroke for lots of different reasons. Guess what? Like cancer, like rare diseases, once you drill down, we will find that within that amorphous stroke population, there are many subpopulations that if we only identified them and we actually were able to target them, we actually would not only do a better job in terms of treating them, but a better job of prevention. We just tell everybody the same thing, you know, eat healthier, you know, do better, you know, without really, you know, understanding what causes that stroke. And so, you know, yeah, you know, and the stroke community, the cardiovascular community, you know, step up and demand in this day and age.
So you know, when we talk about a large proportion of cardiovascular disease preventable, we may be doing ourselves an injustice in that we're perpetuating the myth that it's all down to the individual. As we rightly know, cardiovascular disease has, you know, many contributing factors, not least even the environment and where you live and so forth. So these are things completely outside of people's control. But do you think, is there any case to be made from a rights perspective? Can I say that that people who are living with a cardiovascular condition have a right to receive, you know, the appropriate treatment at the appropriate time, and have a right not to die prematurely. I mean, how strong, if at all, can we take the rights-based approach to cardiovascular health?
Neil, listen to what you're saying. If you substitute the word cancer for cardiovascular patient, what cancer patient would not say, I have every right to get an early diagnosis, to get the right diagnosis, to be able to be treated with the right medicines at the time in which, and think about it if you were talking about it for your child who has cancer. Would you not say, why is it then not different, any different for a cardiovascular patient? I think it really is, a change in the mindset, a change in terms of what it is that you feel, as you say, you have a right to. And of course it's a right. We all have a right to have the very best treatment and care possible. And we have a right to demand that the system actually do better for us.
Yeah. So are we coming back to the point we made earlier that what we're missing here is we're missing leadership in our own community, in the patient community. You mentioned, for example, training. Okay, training for your rare disease community. Do we need to look at how we train and upskill, how we identify and how we train and upskill individual patient advocates? Is that a strategy we should be looking at?
Yeah, of course. And this is not to cast any dispersions, right, on cardiovascular patients. And I go back to looking at two of the most successful patient-led organizations I can think of, the FH Foundations, and also the Arrhythmia Alliance. I mean, these are led by, and originally started with patients and parents, and who really drove, the identification of the causes and the needs. So I think you see examples of it there. The problem is that it hasn't actually expanded sometimes into a really crisp ask and the kind of demands that are necessary in order to, to have action, but also, across, different, as you said, there's a dozen of these cardiovascular conditions and treatments that we think we could do a whole lot more with, but we haven't. So how do we engage people to be part of? I mean, rare diseases, we have 7,000 different rare diseases. We have what we identify maybe as 300 million to 450 million people there. I will guarantee you, we are all one community. I mean, think about that. People identify with being a rare disease patient. They identify being part of the rare disease community. Do people with cardiovascular diseases identify with being part of a cardiovascular community? Do they feel like they're all driving for the same cause? Or do they feel that if what one group wins, it's a win for everybody? I think that's what we, I mean, and maybe it's because it is so big, it's sort of like, belonging to, a group of people that are, bicyclists in general, but well, I shouldn't say that bicyclists have actually come together to demand bike lanes. They've demanded safety. I mean, it's getting that sense of identity and being able to say, okay, we are. I mean, that's why I go back to, not to, say too much, but, the Global Heart Hub, I see as that possibility of bringing in, that heart community. But then it's sort of saying strategically, what are we going to do? What are we going to go after? Are there some, as you called it, some quick wins that we can identify? Are there some overriding, kind of what we call, superordinate goals that we can all buy into, that we can really feel strongly that if we achieve this for one, we achieve it for all, and everybody can come into it. I mean, it is mind-boggling to think of what could happen if you can mobilize, even a vast portion, maybe even a small portion of the cardiovascular community to work as one.
Yeah. Yeah, you've tapped into some very important points there. I mean, the reason why the Global Heart Hub came together was the fact that there wasn't a community, and I'm glad to report that there's an emerging and developing community. Almost every day now, we're approached by patient organizations, and they may be small groups of patients who have come together for different reasons. But so it's growing. So I think we're on the right road. But you make some very good points about having, a very clarity of what the asks are going to be. We need to do a little bit more work on that, because you're absolutely right. When you go in front of a policymaker, it can't be wishy-washy. It can't be something that's unattainable. But there are many, many things that we as a community could and should be looking for. I'm going to just interject with because there's some questions, and I'm delighted to see a strong interest from those on the line and using the Q&A, because there's a question here which sort of fits into what we're discussing about, and it says, do you think that some of the issues with finding individuals to tell their stories is associated with the sense of personal responsibility and blame that unfortunately persists around CVD, and especially among older people?
Yes, I agree very strongly. I mean, I was involved, way back earlier with, when I should say, one of my first, groups I work with is hemophilia and HIV. People are afraid to step up. And part of it was back to the whole HIV, where it was seen as kind of your fault for having HIV, even within the hemophilia. And there was some sense of, we're hemophiliacs with HIV. We're not the other HIVs.
Yes,
and
right.
until we recognize the fact that we're all in this together, HIV is HIV, and there's nobody's fault, right? So yeah, you have to get over that. And in some respects, we do want to make people responsible to take care of your health and eat healthy and da. But you're not going to wipe out cardiovascular disease by doing that. And there is a great deal more. So yes, I think it has been the case that a lot of people that could step forward are kind of ashamed to do so, afraid to do so.
Yeah, and another question there, and it sort of thinks back or links back to what you were talking about earlier about integration between patient and clinician and so forth. It says that quite a lot of the CVD advocacy work that I do is within the medical community. I find that the patient voice is self-limiting in deference to medical professions. I find this very frustrating. Is there a similar attitude from patients in other areas of patient advocacy, and how can CVD patients be more militant in their advocacy? And of course, this is an interesting question because for some people, the term advocacy and militancy, are one and the same. And of course, that's not what we're trying to do. Advocacy shouldn't be perceived as a threat. But what are your views on this?
Well, to be honest with you, sometimes you do have to be a little bit militant. I always tell my favorite story about this old man and his grandson with a donkey. And this donkey has this huge load on top of it. The little boy says to his grandfather, how are we going to get the donkey to carry this load? And the grandfather says, with kindness and rewards. And, we're going to coax him along. And then he takes a big stick and he whacks the donkey on the head. And the little boy looks up at it and says, Grandfather, I thought we were going to do it kindness. And he said, yeah, but first I got to get his attention. So, you know what I mean?
Yeah.
Sometimes you got to get the attention, and that is the case, and it isn't against anybody, and I think that's the challenge. Sometimes we feel when we're doing advocacy within a medical community, it feels like we're against that healthcare professional. So really working with the healthcare professional, finding those healthcare professionals who would actually feel they could benefit by having a patient voice. I think that's what's been so important. And again, I go back to FA, I go back to arrhythmia. Many physicians want to be able to have a better advocacy voice. They want to be able to challenge what they see are some of the limits. They want to have better resources. And so if we can approach them in that same way, we can do more of this together. It isn't against them, right? It isn't their failure. It really is, how can we elevate this together? So yes, you've got to have those side conversations. You've got to have those initial conversations. And so that when you're doing the advocacy, it isn't against those who are your partners, but it's against a bigger system. It's against the limits there. And you've got to make them allies, right? You're not against it. And there were some people who feel threatened. There were some that never want to be involved. But guess what? There will be others who will.
Yeah, and I think again in the cardiovascular world, this is a new area. It's a new area for clinicians actually, and cardiovascular healthcare professionals to find themselves talking about advocacy. But increasingly, in a positive way, I'm noticing reports from different patient organizations engaging with national clinical societies, engaging with the World Heart Federation, ESC, and so forth, that they are beginning to realize that there's greater power together than operating as silos. I have to say, I don't think we've ever had so many questions, and I'm conscious of time, so I'm going to try and so they may not follow a common thread here, Durhane, but I just pick a few of these. One, you made reference to FH, and in the context of ASCVD, so the thing that really sort of strikes me as I look at this is that we have this condition, ASCVD. It's responsible for such an enormous burden. But then there's a subset of that ASCVD which is genetically determined. And we even know that scaringly or worryingly, depending on what part of the world you are, that's in somewhere between 250 and 300 people have this genetic predisposition to high cholesterol. Now, a quick win there, very clearly, is that you have some sort of national screening program. And again, we have some exemplars of this, but we have some countries like our own, for example, in Ireland, where not only do we have not have a screening program, we have no care pathways, we've limited specialisms, we've no national strategy. I mean, it's from a rights-based perspective, it's almost criminal that there's this proportion of the population that have this condition that is likely to be fatal unless there's intervention. So there's a big shout out from the Brazilian Association of Familial Hypercholesterolemia saying, wonderful talk, congratulations. But to the questions, do you think that cardiovascular patients feel guilt? This is probably similar to the previous question in developing the disease. Are cancer or rare diseases considered victims, and why are CVD patients don't post or talk about their conditions in the same way as some of those other areas? Any thoughts on that?
I think so, and I think it's a matter of how society has cast it. I don't think people have done that themselves, right? You do. I mean, in some respects, you look at the Non-Communicable Disease Alliance. They say these are the 5 common factors of these diseases: lung disease, heart disease, cancers, etc. And we recognize that many of them are not only environmental conditions, but are lifestyle conditions. But you don't get that same kind of a pointing the finger at it as you do. So I think it's just a matter of how it's been framed and how people have grown up with it. I also do see, and I saw that one about older people, we have kind of also said, oh, well, you're getting old, you're obviously going to get cardiovascular disease, without absolutely, it's sort of like dementia, at some point everybody's going to get dementia. Well, okay, we won't do anything about it. No, and I think that's where the mental health community has come forth and say, we can do better than this. And I think we need to have that sense that we can do better than what we have here. This is shouldn't be limiting, right? And yes, there are many things. And I think, it is the case that people don't want to talk about it sometimes because they have to point back to themselves, right? But that is not necessarily, kind of I think there needs to be a lot of education around it. There needs to be a lot of awareness around it. I think even with diabetes, right, we recognize this is not just people. It is we don't even know how much of cardiovascular disease includes predispositions, because we haven't tested for them. We haven't looked for them. We've just sort of assumed that, okay, these are all alike. And I think that's, those are critical, when we haven't done the research, we haven't taken the action because we have not been, willing to, as you say, stand up and say, I need you to do this, right? And it has been, in some respects, I don't think it's deliberate, but I think it's in some respects it is. Because I don't have to treat this. I don't have to do the research on that. I don't have to put funding into this because, I'll just kind of blame you and, you can, you feel so bad about it.
You feel bad about it, yeah.
Yeah, you just go away, right?
Yeah. No, it's but as the title of this series is called, the Inspire series, it's great to hear you say we can do better, because we can. And that's why learning from others is so important in terms of the other disease areas. Clearly, the Canadian your Canadian fan club have all logged in. Durhane, my good friend John Stott from Heart Valve Voice has a good question here. He says, Durhane, what are the top 2 or 3 global forums that key decision makers see as essential? Should heart disease patient advocates do a better job of attending and speaking up from a patient's point of view? So there's a lot to that question. Where are the decision makers? Where do they gather? How do we get patient voice, patient advocates in front of them?
Absolutely. I mean, you do have the European Health Forums. You have the GAS9, forums in Europe. Europe has a lot of these that actually, you can make a real case for. And what we, and other disease areas try to do, right, is to actually, number one, you have a lot of scientists there, you have a lot of policymakers there. You've got to get to them to actually be your voice at these. Patients standing up at some of these forums are not really as well respected as if you can get somebody who's already respected to stand up and say, this is what we need. And for them to also say, we need to have patients here. We fight our way into some of these, but the way we get in is not because we do stand outside maybe and do, be the militants, but you really need somebody on the inside to carry your message. And I think it's getting those people that are on the insides to speak up and to make the case in order for you to have that kind of opening. But yes, absolutely. I think the rallying cry should be in the cardiovascular community. We can do a whole lot better than we're doing right now. There's so much unexplored space here. So yes, the patient voice has got to be there, but also what we've done in many of the others, right, is begin to create significant forums that are driven by the patient community that others will come to. And I don't want to overplay kind of what FH has done, but that's what FH has done. Let me set the table. We host a lot of forums in the rare disease space. This forum that we did in Dubai, this was driven by our rare disease community. And people say, why are patients doing this? I said, you know what? If the policymakers were to do it, I wouldn't get invited. I do it and I invite the policymakers. I mean, that we set the table, we set the agenda, we make it significant enough, and we get a few key people, a couple of queens, who are willing to speak on the behalf, and then you get significant attention. So don't be afraid to create the forum and set the table. Exactly.
So John, set the table, and we'll get a few interesting party guests. I've another question in here saying that the points being made are really interesting. Children born with congenital heart disease certainly can't be blamed for eating poorly or engaging in unhealthy lifestyles, but yet when they're treated, their ongoing needs are easily overlooked because their disease is not as visible as other diseases like cancer with visible signs like hair loss. Do you think that because heart patients of all ages just keep going when they are well and are not sick enough looking, that they don't get as much support as other patients? Is that a factor?
It's probably a factor that keeps even people from wanting to kind of speak up, right? Most of us would rather be well than be sick. And when you have cancer, you are sick. You can be deadly sick, right? And certainly go back to, my son or my husband, right? What you do is you minimize your activity, you have more fatigue, you don't show up as much. And those are often things that, are seen as, God, you can overcome that, right? And so it's seen as not as legitimate to actually raise the issue. It's awareness and education. It's reframing those so that it is very clear that these are symptoms of a serious condition and that we need to address this. And guess what? You do not need to go through your life apologizing, for not being able to take as much of an active role as you want, and that there's something that can be done about it. So, yeah, I mean, I love kind of the comments that are coming up here, because I think it does raise, the awareness that, yes, a lot of times we victimize, the victim and make them feel like they're responsible for kind of what the condition is. And yes, there's more that every individual can do, but, that's just not cardiovascular disease, for goodness sakes. That's true for everything. I mean, who lives, the perfect life and lives as well as they should be, right? Nobody. Yeah. The fact that you've got cardiovascular disease and you're living this life and it's actually, maybe contributed to it, does not mean that you're less of a person and have less of a right than anybody else.
Yeah. Lots of questions and comments. One referring back to the last question raised by John. Based on your experience, Durhane, is there an opportunity for reverse education, patients educating doctors, not the other way around? I think you've answered that. There's another question here. Do you have any hope that COVID-19 and its apparent impacts on cardiovascular health, including in people without pre-existing CVD, could act as the catalyst that could drive urgency in CVD advocacy?
Yes, if everybody's willing to rally around that. I mean, that's the whole point, right? Do not take each one of these children born with cardiovascular disease, people that have, kind of conditions that could in fact be mitigated if they were diagnosed. Do not see them as totally separate, right? It is a joint community effort. But I'll tell you something about COVID that actually strikes me. COVID has had greater impact in patients with cardiovascular disease than almost any other, maybe, lung diseases, etc. But and yet we've seen lots of studies, we've seen lots of challenges in terms of how cancer patients are being neglected, how their cancer is getting worse. I saw recently a study that looked at how many cancer patients are actually going to die and have, because of COVID and they couldn't get in for treatment. Where's the studies on cardiovascular disease? Why aren't the cardiovascular patients say, wait a minute, I didn't get my surgery, I didn't get my appointment. And we know that. I mean, I've had a patient who just told me recently, I was scheduled for, surgery and it was put off. I was actually going into and in the waiting room, and there was no more space in there. I mean, where are those studies? And I do think that, yes, cardiovascular disease patients have got to also, be able to stand up and say, this is the impact on us. And as you say, long-term impacts on cardiovascular disease, where's the research that's going to help us better understand that and to be able to mitigate that? Use that as a point, not just for them, but for everybody.
Yeah, and you're tapping into another area of deficit now when you look at patient-led research and patient data. This is something the rare disease community, cancer community have been very good at doing. And again, until we get a movement, until we get enough people engaged, I think we're going to fall far short there. And of course, it's so important to have that data. You're absolutely right. And unless somebody's doing this research, we're not going to be able to make noise. This question is maybe not as easy to answer. The learning curve to become an advocate is steep. So I'm not quite sure what the questioner means by that, but they're saying, how can we make it easier? So yeah, it's a hard question to answer, but I guess what's the route to developing good, strong patient advocates and doing it quickly and easier?
To be honest with you, it's one patient at a time. To me, it always follows the pattern. You've got to get individuals willing to be leaders, willing to put their story out there. You've got to do the awareness campaigns. And in the age of social media, we can do that better than ever if we've got a cause for it. And we've got to be able to get to those healthcare professionals on site, decision makers. There are tons of people that are policymakers that have cardiovascular disease and have it in their families. Make them allies, right? So there's no shortcut to it. All of those pieces have to be done, but they can be done. And the good news is that because there's such a vast community, you can really have those few sparks. I mean, rare diseases, good gosh, I have, families of 2,000 people, it's hard to find, that strong advocate. We ought to be able to do it here. The problem is, it's that, hiding in numbers, right? The more people you've got, the easier it is to kind of be invisible. I mean, that's the challenge, right? It's the old, bystander effect, right? Somebody else will do it. Somebody else will stand up. I can hide in the crowd. Not so easy if you're rare disease. It's a lot easier if you're cardiovascular.
Yeah. And on that note, we're going to have to unfortunately wrap it up. I could spend the afternoon chatting to you, Durhane. As I said, that cab ride we shared together, I got so many great insights from you. And again today, and I can see from the comments here, you really are an inspiring speaker and an inspiring advocate. And I really, what you said there 2 or 3 times in your presentation, we can do better, and I think we can. There's a lot to be done, but we can do so much better, and that's the positive note on which to end today. I would just like to thank you again, Durhane, for being so supportive of the Global Heart Hub, not just now, but in recent times as well. And I hope we can continue to work closely with you. I'd like to thank everybody who joined us this afternoon. Very strong interest on this Inspire series. I have to thank my colleagues, Olive Fenton, who of course put this whole presentation together, my colleagues Jackie, Mariana and Idel, without whose support we couldn't make this possible. And I just want to close by reminding people of the next Inspire event, which is Wednesday, the 11th of May, from 3 to 4 p.m. GMT. Please watch out on our social channels for this. We'll be speaking to John Barrick, and he has a very strong experience across a number of different therapeutic areas, but most notably and most recently in relation to stroke. And sometimes stroke is viewed as the poor relation of cardiovascular disease or heart disease. So if things are difficult for us, how difficult must they be for the stroke community? And bang on time, I'm going to draw this session to a close. To those of you whose answers or whose questions we didn't get to answer, apologies. If there's any questions there we feel we can revert to you on, we will, of course. And Durhane, once again, thank you so much. Great chatting to you, and continue your great work across the many areas that you're advocating for. Take care and goodbye.